However, substantive comments, questions may not be addressed in real time. The chat feature will be open for the last 10 minutes. The council will determine how to address any public comments or questions that we do not get to today. The recording is in progress for note-taking purposes and for any council members not in attendance with us today. All future meeting dates, agendas, and minutes will be posted on the BHA website, and any questions or comments regarding the council or BHA can be submitted via the Contact Us section of the BHA website. A reminder of our current group agreements, which we will hear more about this later in BHAAC business. But our current agreements are to listen and engage respectfully, to remember that differences of opinion are natural and useful, have an open mind, be curious, and be bold. Everyone has equal voice and valuable contribution. Take space and make space. Keep to time and agenda, start and end meetings on time. No acronyms, please. And it is okay to turn off your camera and take time to reset at any point during this meeting. At this time, I will pass it over to your chair of the day that was voted in last month. Our chair of today's meeting is Raquel Garcia.
Good morning, everyone. Welcome, welcome, welcome. I hope you're doing wonderful this morning. I always like to say, I hope this finds you blessed and highly favored. This is definitely coming to you from a blessed and highly favored place. Excited to be here this morning. We are going to start off with a roll call, and it is Shane taking roll call today, Megan, correct?
Yes, it is Shane.
Absolutely. Thank you.
Raquel Garcia present. Hi, Shane.
Hello, everyone. Yeah, I'm Shane. I'm new here, and I use he, him pronouns. So starting to get to know everyone and everyone's name. So if I mispronounce anyone, please correct me. I'm learning and would appreciate that. So I have Karen Renee Anderson.
I'm here.
Annette Smith has joined the meeting.
Can you hear me?
Yes, thank you.
I want to be sure.
Yeah, appreciate it. Nor Shafi.
Present.
Thank you. Ashley and Nan. No. Okay. Rayanne Shaner.
Shane, I think that the one you just said was Ash. Anna.
Okay.
Just wanted to make sure. Okay.
Yes. Okay. Ashana. Okay, and Rayanne Shaner. Robert Archuleta.
Here.
Thank you. Andrea Savanich. Jamie Ulrich. Carolyn Hall. Cameron Vigil. Tasha Conker.
Present.
Thank you. Catherine Washington.
Present.
Thank you. Dr. Kay Runley Leah.
Present.
Thank you. Seth Watkins. Maria Martinez. Selwyn Whiteskunk. Dr. Stacy Oberly.
Sorry, I'm here. Selwyn.
Oh, thank you. And yeah, Dr. Stacy Oberly. Great. All right, thank you, everyone.
Thank you. We'll go over our agenda for today. We did, call the meeting to order. I'll go ahead and officially call this meeting to order. We went ahead and took roll call. We'll vote for a tentative temporary chair for the May meeting if we aren't able to do that prior, and getting all of our members on board to vote. We'll go through a January meeting minutes and approval. And then we'll have a commissioner update from our interim commissioner, Mrs. Barnes. We get to welcome Commissioner Smith today. That's awesome. And then we will go over BHAAC business. We'll take a 15-minute break between 10:15 and 10:30. And then we'll have a legislative update. We'll talk about performance monitoring hub overview and discussion. We'll talk about care coordination. We'll have a care coordination overview and discussion. And then we will open for public comment between 11:50 and 12 p.m. All right. So our first order of business is to vote for a temporary chair for our May 16th meeting. Would anyone like to step forward, move forward, raise your hand, and come in and join us as a chair for the May meeting? Anybody interested?
I just want to share a quick reminder to you all that chairing the meeting is a great opportunity to step up and volunteer to experience this. I know we've had several of you step up, and you're not alone in this. And so if you are chairing, you have support from the BHA as well as support from your peers to walk you through it and make sure that you feel confident in being able to take that that volunteer leadership opportunity.
I'll do it if no one else. Just because Megan made me feel not alone.
I'm glad I made you feel not alone.
I had like voodoo eyes on you, Robert.
I know, I could feel it.
Did you feel it?
Yeah.
All right. Anyone else? All right, let's go ahead and take a vote. Anyone want to make a motion?
I motion. Tasha Conquer.
All right. Motion on the floor to approve Robert as our temporary chair for the May 16th meeting. Do I have a second?
I'll second it.
Thanks, Nora. Thanks, Carolyn. Let's just make this easier. And anyone opposed to this, raise your hand. All right. So moved. Robert will be our chair for the May 16th meeting. Thanks, Doc. We will go ahead and move forward and we'll review the January. We have everyone should have gotten our pre-packets to review the January minutes and be able to access those. So we need to move to approve the minutes from the last meeting.
I make a motion that we approve the minutes from the January meeting.
I second that. Tasha
So
Conquer.
seconded. We'll make this easy again. Anyone opposed to the meeting minutes from January? So moved. The January minutes are approved. They'll go on record. And now I get to hand this over to Commissioner Barnes, or Commissioner briefing from advisor Michelle Barnes. I'm getting there, Michelle. I saw the twist in the words in the change because we do have a new commissioner. Michelle, it's your turn. Take it away.
We do. Good morning, everybody. It's nice to join you for my last meeting at the BHA. Yes, I'm right. Our new commissioner, Danette Smith, has joined and will be here momentarily to tell you a little bit about her and her vision. I think you're really going to be pleased to get to know her. I do want to just give a couple updates because Danette is now, I think she said this morning, 72 hours into the job and doesn't necessarily have all the updates on everything happening here, but she will. So we're onboarding her as quickly as possible. I have absolutely enjoyed getting to spend time with her and onboard her. And I know you are going to absolutely love her. So very happy about this. I do want to say I feel really proud of some of the things that have happened at BHA over the last year. We have a lot to do. And I think you all know that very well, which is why you're on this advisory council. We're on a long road with a very steep uphill. And I feel like we've done a lot of heavy lifting this year. Just want to mention a couple things. One of them is one of the requirements of the Behavioral Health Administration is to license behavioral health entities. This has been a massive lift, probably the biggest rule package ever to go before the State Board of Human Services. Our team was out doing stakeholdering nonstop for months and months and months over the last year and a half to try and make sure we do it right. It's been a year and a half to make sure we do it right. And the rules were passed and we're now into implementation. And this is going to be a really huge impact on providing quality and safe care around the state. I will be honest, there are kinks. It is not perfect. We will be making changes. We will be going to the state board and asking for revisions. It is not perfect, but it's a massive lift and really shows our commitment to quality of care. A couple other things we've done is one of the other huge responsibilities of the BHA is to collaborate. And we've worked with all the other state agencies to really focus on rolling out our BHAACs, which you're going to hear more about later and you've heard a lot about. So I'm speaking to the choir. But we made the decision to delay the BHAAC rollout a little bit so we could do it right. The expectations from the legislature were not, they just weren't doable. We could do it, but we wouldn't do it right and everybody would suffer. So we got a delay on that and we've been able to do a lot of community engagement again. And the BHAACs are, the RFP is coming out very soon. We did an RFI to get feedback and we collaborated with HCPF to make the RAISE regions and the BHAAC regions the same. Now, this may seem like whatever, but it's huge for providers. It's huge. And in this BHAAC rollout, we have really focused on reducing administrative burden. Some of you on the call are providers and have been very helpful in helping us understand the world from your lens. A lot of other providers have too, and they've made it really clear that the administrative burden that the state puts on them is absolutely not okay. You didn't get into business to be filling out forms for the government, so HCPF could have forms in their world, and BHA could have forms here, and CDHS could have forms in public health. That doesn't make any sense. So we're working on that. And that's been a huge collaboration as we roll out the BHAACs. I also want to tell you something kind of fun. I think I stopped into the best offsite I have ever seen in the history of my career, and I am old. Our technology team got together for 4 days. They gave up their weekends, and I think they went to Meow Wolf and other fun things too, but and a little hiking. But they got together for 4 days to really talk about technology. How do we take our technology to the next level? Sorry. I'm drinking decaf coffee. I don't know where this is coming from. How do we interconnect government? How do we reduce admin burden? How do we use better data? There were 54 technologists from BHA in this offsite. I frankly didn't know we had that many. And then I found out why I didn't know we had that many, because our technology team is brilliant. And they went out and hired some of the best tech minds in the North America, because we have some Canadians, ex-Canadians on it, and they brought them on contract. So a lot of these tech geniuses are parents and caregiving their family members, and whatnot, and they don't want to work full-time. So we brought them in as contractors. So we have 54 people, most aren't full-time, that are creating the best-in-class technology system so we can reduce admin burden and have better data. All that's rolling out pretty much some things now like the learning hub that you'll hear about later, but a lot of the rest of it will roll out over the next year. I am thrilled because having a different technology infrastructure really launches us into the next phase of where we need to go. The last thing I want to mention that I'm really proud of is we all know, and all of you have been on this journey for many, many, many years, knows that we in Colorado did not have a children and youth behavioral health system. We had lots of brilliant providers. We had some reimbursements. We had a lot of passionate people, but the system didn't fully connect. A lot of times it was the adult system, and then we just put kids into it, and that didn't work. So we've worked over the last, gosh, maybe 8-9 months to work with other agencies and providers and a lot of community engagement to come up with a plan to really address in measurable ways the children and youth needs in our state. And I'm very excited about it. We're just starting into implementation. You're going to hear more about it. I see Matt is on the call. He's one of our leaders on that. Kelly Causey joined us from Children's Campaign and is our head deputy commissioner working on that. Very excited about that. Colorado's never done that before, but we're doing it collaboratively and with the community. I will say, one other thing that I know has been on a lot of your minds and you guys have had concerns about was the hiring at BHA. We have a lot of open positions, but we have filled a lot of open positions. Every month we do a list of who's, warm goodbyes and warm hellos. And we have massively grown our workforce. We still have a lot of open positions. Keep checking, referring your friends. Please, please, please. I want to mention 2 of them just because you guys might be able to help us with this. One is Danette is hiring a deputy commissioner of administration that'll oversee our contracting, our CFO, our HR, our systems, our results-driven management, and they are currently interviewing for that position. So have some great candidates. And based on the great success we've had bringing people from the advisory council into the hiring panels, Megan will be reaching out to get someone to join that hiring panel. We had representation from BHAAC at the last 2 deputy commissioner hirings, and I will tell you, your contribution was invaluable. And I hope you will take the same pride I do in how great these 2 are doing, Erin and Kelly. And so that's something we're going to continue at BHA. It's also something I'm going to take back to CDHS and always have somebody from one of our advisory councils, our Family Voice Council, on hiring panels. So thank you. You've changed 2 agencies with that. And the other position I want to mention is under Megan, we are hiring 4 people that are going to be in community, in region, doing community engagement and making sure that if something's going on in Walsenburg, we're not all sitting around going, where's Walsenburg? What do we know about Walsenburg? Who's the mayor? We're gonna have someone in community that's learning, that's understanding, that's raising issues that people can go to. So those are 4 positions that are posted currently. They're all remote. So we want you living in the communities. So please consider, if you know a friend that's passionate about behavioral health, or if one of you are, I'm not gonna try and poach by any means, but I just want to let you know, we do have 4 remote positions that we're hiring for right now. And the job openings are still open. We also have Danette's executive assistant position open. So if anybody knows someone who's a great executive assistant, we're currently recruiting for someone to support Danette. One thing I want to mention that we're going to talk about in a town hall coming up. I know some of you are very concerned about the delays in getting us paying out on our ARPA grants. It is a real issue. We are all over it. We are doing daily huddles with cross-functional teams to figure out what processes we can change, what systems, what troubleshooting, what more resources we can put on it. We have heard you, and we are responding as aggressively as we can with a very small team. But we hear you. Please keep telling us where there's a challenge, where you need help, where we need it. Tell your friends. We are here. Call me, call Danette, call Stephen. call anybody you know at BHA. We are all here to help you guys, and don't mind having people reach out at all. But I want to let you know we also heard you, and and I think my next meeting after this is to follow up on the action items we had yesterday, where we're trying to see how we can improve it. So thank you for that. And as for me, I'll be on the meeting all day today. I want to hear what you have to say. I am going back to the Colorado Department of Human Services, which I have been on leave from for over 11 months. And I'll be the executive director over there. And I've learned so much from my time with behavioral health. I will be a significantly better commissioner or executive director of CDHS because I have a lot more experience in behavioral health. Particularly the area I didn't have a lot of experience on is substance use disorder. And I'm really so grateful for the opportunity to learn about that and be able to take that back and be more compassionate, more understanding, and more community focused as we work on that from CDHS. For those of you guys who know, CDHS is a very large, complex organization, and we do run the state mental hospitals for people that need hospital level care to deal with their behavioral health concerns, or people that are justice involved and need to get restored to competency so they can participate in their trial. We run child welfare, we run adult protective services. We have homes for people with disabilities. We're the safety net for people with disabilities that need housing around the state. We are opening a lot of step down group homes for people to exit higher level of care to be able to go back into community. We run SNAP benefits, food assistance benefits. So we do a lot of things for humans, and many of the humans we interact with have behavioral health concerns. And one of the things I've learned from my year at BHA is every human being has a behavioral health concern. If you lived through COVID, you experienced loneliness, you experienced isolation, you lost people you loved, you felt scared, you felt angry, you worried. Like, I think everyone now understands whether it's just a little challenge that you can deal with yourself, or whether it's a massive challenge and you need to be getting a hospital level of care. We all have a better understanding of how hard it is to be a functioning human. And so I thank all of you for really helping me with all that. And I will make the thing, I will put my phone number and email again in the chat. I won't be at BHA, and I'm so proud that we have someone of Danette's caliber, but I will be still part of the team, the fight, the challenge, the initiative, the reform, just from a different vantage point. So please, if there's anything I can do for any one of you or your companies or anything else, please do not hesitate to reach out. I had a chance to get to know so many of your stories, and I will not forget that. And I am here to support you. So with that, I'm going to stop talking and invite our new behavioral health commissioner, Danette Smith, to tell you a little bit about herself and her vision. Danette?
Thank you, Michelle. Can everyone hear me okay? Can you hear me? Okay, great. I have a really deep voice, and so sometimes my voice carries. Michelle, thank you so much for the introduction, and thank you so much for all that you've done to make sure that my onboarding here into Colorado and into the behavioral health administration has gone well. I really appreciate how you've approached me and how we're working together, and I just thank you for all your time, because you've given a lot of time to make sure that I'm up to speed. Thank you so much, Advisory Council, for inviting me to your first meeting. I am excited to be here in Colorado. Quite honestly, I have worked all over the country, and I won't go through where I've been, but what I can tell you is I'm originally from Indiana. My career started in Chicago, Illinois, and I've worked all over the country. What you can expect from me is really to leverage all of the experiences that I've had. I'm a human service professional, so I have ran all of the major programs across the country in human services. And what I'm hoping to do is to bring that knowledge and expertise to how we build a strong behavioral health system here in Colorado. You've heard Michelle mention what I know is very dear to the staff that I've already met is the services that we hope to provide to children. But we're also looking to how we're going to provide behavioral health services in a coordinated, integrated fashion to adults as well here in Colorado. I've been doing human services for a very, very long time, and I can tell you we are probably the only state that is taking this level of action to inculcate and to put behavioral health into the systems where it is accessible, it is affordable, and anybody who needs it is able to access the services. And we're doing that through an integrated approach. We're doing that through building up our workforce and making sure that we have rules and legislation that follows what behavioral health should be here in Colorado. My own experience in behavioral health is in several programs, one dating back to Chicago when we just used to do community organizing around getting people to behavioral health systems in Chicago and sometimes into the state hospital, all the way to Virginia Beach where I worked with law enforcement. Instead of arresting people, let's get people treatment. And then in Nebraska, working a lot with children who were in the juvenile justice system, but had significant behavioral health issues to really transform those programs to be more clinical and less correctional. So my experience in behavioral health for adults, systems, substance use disorders has been extensive, and I hope that I'm able to leverage my human service experience to come and work alongside of you in making sure that Colorado has the best behavioral health system in the country. I have 2 daughters. My daughters are both grown. One lives in Fort Worth, Dallas-Fort Worth area, and the other one lives in Raleigh-Durham or Raleigh-Cary area in North Carolina. I had a dog by the name of Mr. Bentley, but Mr. Bentley has thus passed this last year. So I'm here all by myself. But I'm looking forward to the work that we're going to be doing together. I think there is a phenomenal team here, and I'm looking forward to working with this team. Might there be any questions that you want to ask me?
Thank you for that introduction, Danette. And BHAAC members, there is time in the agenda for you to have a Q&A with Danette. So please feel free to ask the questions. I know you all have been reaching out and asking lately with your curiosity. So welcome to take this time to do that.
I have a question. Hi, Commissioner Smith. Welcome to BHAAC. So glad to have you here with us in our community, and welcome to Colorado from a native Coloradan. Welcome. What efforts will be made to know us as individuals and as a council? One of the things we really enjoyed from previous was that we did know on a personal level what each of us either contributed in the community from our previous commissioner. Mm-hmm. And so I'd like to see that was something that similar thread continue. And how will you engage with us in that manner?
Yeah, thanks for the question, Raquel. I am a person that likes to work out in the community. And I didn't even get into the community organizing piece of my background because that you don't want to hear about all of that. But I think it is important that I get to know each and every one of you. You should know that I want to work in the community and that I will be very visible in the community all across the state. I was very visible in Nebraska, and in each of the jurisdictions where I worked, all the councils that worked with me or worked under my leadership, I knew everybody and they knew me. They had a sense of what my mission and purpose was going to be in the organization. And what I don't want to do this morning is to get into sharing all that detail because I've only been on the job for 72 hours. But what I can tell you is that I am going to reach out to you. I do want to meet with each of the members of the council and get your sense of how BHA is moving forward. And then we go from there. and we figure out how we work together. So I will not be a stranger. I will not just sit in Denver. I want to be out and about learning and listening and exploring with you parts of Colorado that I do not know, so that as we're making decisions here in BHA, they're informed decisions. And
Thank
quite
you so
honestly,
much,
Raquel,
Commissioner
you might
Smith.
get tired. You might get tired of talking to me. Okay.
Oh, I don't know. If you know that you've researched this council, I'm sure I could do the same. You might say the same about me someday. Thank you, Commissioner Smith.
You're very welcome. Thank you for the question.
Absolutely. I see Dr. Archuleta and then Miss Renee.
Hi, nice to meet you.
Nice to meet you.
I first of all wanted to say thank you to Michelle for all of the work she did while we were kind of waiting to get someone hired in the commissioner position. So thank you. And then I kind of had a similar question that Raquel had, and you answered some of it, but I already had my hands up, so I'll just go. So it was meeting with providers, meeting with communities, because often, you know, I know you've only been on the job for 72 hours. And so I'm hoping within another 24, you'll be to Pueblo, Walsum. No, I'm just kidding. But I do think it's important to come down before policies are made to speak to providers, to speak to people in those communities, because often it happens backwards. It often happens, something is put it or implemented, and then everybody, you know, goes crazy, and then we get a visit. It would be nice to have a visit, you know, and sit down with providers in the smaller communities and even in some of the bigger communities, just all across Colorado, because that way to hear us and to know, like, you know, to listen to some of our concerns, and honestly, for some of us to brag about the good work we do as well. So just having a chance to meet before a lot of the policies are pushed forward, because some of the conversations that you have with providers, I think, could impact decisions being made.
So, Robert, I've had a history in my career of meeting with providers on a very frequent basis, and I'll give you two examples. When I was in Nebraska, I was meeting with the behavioral health providers to really look at how we better utilize state hospitals and utilizing state hospital beds. We had some interest from DOJ to come in and look at how we were discharging patients. And in order to do that work right, I needed to meet frequently with the behavioral health, my regional authorities, as well as the providers, to come up with a process of what does behavioral health look like with state hospitals, but what does behavioral health look like in the state overall. So in terms of meeting with providers, with the regional authorities, that's how I tend to operate. I will be very honest with you. Those things that I can share in terms of policies and procedures, I'm definitely going to do it. But I'm also going to leave myself room enough to say there may be some things I can't share right away because it's just not time to share it. But I'll let you know that. So you can count on me to be very engaging, to be very spontaneous, to answer your questions when you call, and to make sure that you have good information that you're able to share with your constituents back out in the community. Again, we cannot do this work without you. We have to do this work with the community. And what that means is that the commissioner and her team have to be visible. And so that is one of the goals that we want to make sure that we achieve.
Thank you.
Miss Renee.
Welcome, Commissioner Smith. This is great to have you on board. I am Renee Anderson, and I live in rural frontier area. And this is an area, I mean, it's a lot of Colorado is in the rural frontier. And there's a lot of lacking, a lot of services that are needed. And I'm hoping you will come to these rural frontier areas and meet with the people, see the things that they are truly in need of, as well as something I think that you've touched on is youth and the Department of Justice, and how many times, especially in these rural areas where services are not easily to come by or even close by, that these youth are not criminalized because of their substance use disorder or other issues that they may have. So I welcome you. I'm excited, and come down to my area and I'll treat you to lunch.
Oh, that'd be awesome. That'd be awesome, Renee. Let me just say this. When I was in Nebraska, I went all over the state, from urban to suburban to rural to the panhandle. And you know that much of Nebraska is the panhandle. I went wherever I was needed. And I was known in those regional areas for getting things done and being a good listener. So listening and then putting the steps in place to be able to serve the people that we were supposed to serve. So I'm not frightened to go anywhere. I want to be seen as a visible leader. I want my team to be seen as a visible leader, and that we're here to listen, learn, and then be able to implement as appropriate what we hear from you. So you can count on us for that. Being in rural communities, quite honestly, Renee, and I'm being, pretty transparent with you, doesn't frighten me at all. I did it a lot in Nebraska, a lot. And I built a lot of supportive relationships to get some things done legislatively, that if I hadn't have had those relationships, some things simply couldn't be done.
Awesome. Well, get your track shoes, because we have almost 105,000 square miles in this state. So we need you everywhere.
Thank you.
Thank you so much, Renee. Dr. Lee.
Thank you, Raquel. Thanks also to Commissioner Barnes for getting us to today, and welcome Commissioner Smith. So I'm Ron Lee. I'm a child psychiatrist and oversee mental health for Children's Hospital Colorado and on the CU Anschutz Medical Campus. We're really excited to have you enroll. We're really excited to have the BHA leadership team enroll as well. You'll find from the BHA Advisory Council, this is a really tough, resilient group who've hung in for the last couple of years. So I think any support that you need in onboarding or in getting to know different aspects of behavioral health care across the state of Colorado, whether it's adult or child or family or community, mental health and well-being, we're here to serve as a resource as well. I guess I would love to hear a little bit, because I'm representing the integration of mental health services, substance use services, and traditional health care, so primary care, hospital-based care, on the full continuum. Would love to hear your experience and thoughts about integrating mental health, substance use, physical health services.
Let me tell you, we were beginning, Dr. Lou, to have those conversations right before I left Nebraska about what it looked like to have integrated care. And we were also beginning to look at some public health strategies on the prevention end. What are the upfront services that we could do prior to doing something around intervention? And so those conversations, I would say that I don't have a platform that I could talk about, but I can tell you that we had started those conversations in Nebraska about what would integrated care begin to look like, what would be some prevention strategies on the front end that we would use to make sure that we were galvanizing support for people who needed it before significant intervention was needed. So I have some familiarity with it. I am not the expert, but I know that is a needed area of where we need to go in terms of integrating physical care and behavioral health care. And I was just starting to have those conversations before I left Nebraska.
Great. So we'll continue them here in Colorado then.
Absolutely. Absolutely.
Ooh, I went in on that conversation. That's exactly what we do. Carolyn.
Sorry, I had to unmute myself. I want to say thank you and welcome. I'm so grateful that you're with us. And I really appreciate your enthusiasm and your dynamics that you bring to the state of Colorado. And I also want to thank Michelle Barnes for bringing us to where we are as well. I kind of want to add to that, because I think my fear is when there's change that things sometimes get lost. And so what I'm hoping is, like, I know one thing that I don't want to see get lost is where people will eventually have the ability to go where they choose for their services, and so I just want to make sure, like, the things that we've been working on will continue to stay, and that we can continue to work on it. And I know you're only 72 hours in, but I just think I need a little reassurance that we're going to keep moving forward with what we've already started.
I believe we are, Carolyn. If there's a need to explore or change anything, I'm certainly going to make the advisory board aware. But I think right now we're proceeding where Michelle left off. To be honest with you, I don't see a need to change anything at this point. I wanted to go back, if I may, to Dr. Liu's point, and this is blame it on a senior moment, if you will. One thing I did want to tell you, and I just forgot to mention it, in Nebraska, we had a relationship with the Children's Hospital. And the Children's Hospital did all of my physicals and behavioral health assessments. That's the integration you're talking about. So all the kids that were in care, they did all of their physicals and they did behavioral health assessments, so that if we needed to triage a child for behavioral health services or for physical care, that could happen at the Children's Hospital. That's an example of something that was going on during my 4 years in Nebraska.
Yes, Commissioner Smith, I just met with your Nebraska team, so I've heard about that good work.
Yeah. You know Dr. Haney?
I worked with the Children's Hospitals team. We just convened them all, and this is the kind of model, right? You want to bring in your, yes, yeah, absolutely.
Right. And so the next step was then to be able to share caseload information. And so we were right at the brink of bringing somebody in that would allow us to have medical information and for them to have some of the child welfare information, so that as they're making decisions as a team, where my staff used to sit, they are going to take into consideration behavioral health and physical health of the child. I just wanted to go back and say that, because I don't know how I could forget that. And then back to you, Carolyn, I want to assure you that right now we're moving forward with the plan as it is. As things get tweaked, because I want to be honest, there may be things that get tweaked, we're going to make sure that you're in conversation with us.
Thank you very much.
Thank you, Carolyn. Thank you, Commissioner Smith. We have 6 minutes left on our time before we have to move forward. But Tasha, your hand's up. I'm just making us mindful of time. Go ahead, Tasha.
Hi, Tasha Conker here. I just want to give a shout out to Michelle Barnes. You definitely have put up with a lot from this council. And I know I was a pain throughout this time, but I want to thank you for your time, because I see the change coming. So I want to give you a big heartfelt thank you. And then Commissioner Smith, I am so excited to collaborate with you. I did some research on your stuff, and what you did for Nebraska has been absolutely, it's mind-blowing to somebody with lived experience. Thank you for holding to transparency and accountability. I just want to, I'm looking forward to working with you guys and collaborating and keeping us updated on legislation updates and everything else. So that's, yeah, I just want to say thank you and welcome to Colorado. And you're not alone here, because you got us.
Thank you, Tasha. Thank you so much. You will be hearing from my staff. They are putting together kind of a listening tour for me of key stakeholders that I need to meet with. If you feel as though you're one of those key stakeholders, if you would reach out to Kelly, and Kelly will kind of get you set up to meet with me. I'm doing some listening tours as I kind of get onboarded. And then finally, what I would say to you, which is what I've been saying to the staff, I came to Colorado to serve. I want to serve with you and for you. And I want to do the best job that this commissioner can do. We got a lot of work to do over the course of the next year. And I hope that I will be able to develop a really, really strong partnership with you. So you can count on me to be here to serve and to support Colorado during my tenure here. Looking forward to it.
Thank you. Looking forward to it as well.
All right. Thanks, Tasha. Thanks, Commissioner. got a couple minutes. Any last minute questions before we move forward?
Raquel, there is a question in the Q&A.
Okay.
I can go ahead and read it if you'd like
Go
me
ahead.
to.
Yeah, go ahead.
So this is from a member of the public. How will you ensure that children are not being moved into the child welfare system just to receive behavioral health care?
You know, Megan, I don't know right now that that's something that I can take on. I know that Michelle and I will continue to work closely together so that whatever we do from a BHA standpoint includes the children that have the potential to come into the child welfare system, as well as children who are already in the system. This morning, I had a wonderful meeting with HICFA about what they're proposing in terms of services for children and adults. And so I think that person just needs to know that's on my radar. But what I plan to do is to work collaboratively with already the state agencies that have that responsibility.
Thank you, Jeanette. And this person responded to please include this topic on your listening tours. And so I will take the initiative to communicate that with Kelly and ensure that we are keeping this in mind in our engagement plan.
Thanks, Megan. Thanks, Commissioner. All right, if there's no further questions, we can move forward. We're going to move on to BHAAC business. And the end of last year, us as a council decided that we wanted our agreements to be written by for us, about us, by us. And so we did speak about what we wanted that to look like yesterday. Everyone was sent a document showing the upcoming or new agreements that we are agreeing to. Excuse me. Those agreements are, number one, we'll have respect for diverse perspectives, and that we acknowledge and honor the richness of our collective experiences and commit to listening with an open mind to perspectives that differ from our own. Our second agreement is that we will cultivate empathy. We strive to understand each other's backgrounds, cultures, and lived experiences, fostering an environment of empathy and mutual support. Number three, open communication. We value open and honest communication, encouraging everyone to express themselves freely while being mindful of how our words impact others. Number four, create space for learning. We recognize that we all have room to grow and learn from each other. We commit to creating a safe space where questions can be asked and knowledge can be shared without fear or judgment. Number five, acknowledge the power dynamics. We acknowledge and actively work to address power imbalances within our community, ensuring that all voices are heard and respected regardless of rank or position. Sorry. Six, accountability and responsibility. We hold ourselves accountable for our actions and words, recognizing the impact they may have on others, and we commit to taking responsibility for any harm caused and working towards reconciliation. Number seven, promote inclusivity and celebrate diversity. We strive to create an inclusive and diverse environment where everyone feels welcome, valued, and celebrated, actively challenging discrimination and prejudice in all its forms. We recognize that our differences are a source of strength and innovation. 8, a commitment to equity. We are committed to promoting equity in all our decision-making processes, striving to ensure that everyone has equal access to opportunities and resources. 9, continuous reflection and improvement. We commit to ongoing self-reflection and collective evaluation of our practices, continuously seeking ways to improve and better serve our community. I think I'm 10. My numbers were messed up on my sheet. Listen and engage respectfully. We commit to actively listening to each other's viewpoints and engaging in discussions with respect, even when we disagree. We value the diversity of perspectives within our community. 11, I think, in numbers. We have an open mind. We approach discussions with curiosity and open-mindedness, recognizing that different viewpoints contribute to our collective understanding and decision-making process. Be courteous and bold. We encourage bold ideas and courageous conversations while maintaining courtesy and respect towards each other, ensuring a constructive and supportive environment for all. Equal voice and valuable contribution. Regardless of position or tenure, every member's voice is valued and every contribution is considered important to our collective efforts. Take space, make space. We recognize the importance of both speaking up and creating space for others to share their thoughts. We encourage balanced participation and actively inviting quieter voices to contribute. Keep time and agenda. We commit to respecting everyone's time by adhering to the meeting agenda and ensuring timely discussion of agenda items. Explain your acronyms. To ensure inclusivity and understanding, we agree to clarify any acronyms or jargon used during discussions, promoting transparency and accessibility for all members. And final, it's okay to turn your cameras off. We understand that everyone has different comfort levels with video conferencing and respect each other's preferences regarding camera usage during virtual meetings. Those will be that's the long of our agreements. And in future meetings, we will all have an understanding of those deeper agreements, but we will just put the highlights on the slide deck. So, any open discussion or feedback on the agreements? Some hearts. Okay, that's great. Any suggestions from the team? Okay. So if there's no discussion, I'll need a motion to vote in our agreements.
Tasha Conquer, motions.
Second?
I second.
Carolyn?
I'll second
Norm?
it. Thank you.
Thank you. So moved. Oh, wait, actually, hold on. I have to say, all in favor. All in favor.
Aye.
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 Thanks, Robert. I see all the hands coming up. All opposed? So moved. We have beautiful new group agreements that were written by us, for us, and about us for our community. Thank you, ladies and gentlemen. Thank you, thank you, thank you.
Raquel, thank you for taking the lead on this, and BHAAC Executive Committee, thank you for all of your work and contributing to this, and to all of you that responded back to Raquel. I know Raquel sent out several emails on this, and just really appreciate all of you coming together, and most importantly, you bringing this to our attention, that that slide had been created for you and not by you. I really appreciate your recognizing that and letting us know, and then collaborating to make it exactly what you want it to be. I think this is a really great example of BHA and BHAAC working collaboratively. And I'm really excited to see this continue to move forward in this direction. And so my commitment to all of you is I will replace the current group agreements slide that we have, and we'll add the list of all. There's so many wonderful, beautiful things written on here, and so it will just be a list without the definitions, but you all have a copy of that Raquel sent out to you all. And so I will also upload the copy that Raquel created with the definitions into the BHAAC shared drive so that you all can access that at any time.
Thanks, Megan.
Hey, Raquel, could I ask a question real quick?
Absolutely.
So, Commissioner Smith said to contact Megan for a speaking tour. I just thought it'd be nice to point out which Megan. There's like 4 or 5 Megans on these meetings. So sorry, which Kelly, not Megan, which Kelly? Because didn't Commissioner
Kelly
Smith,
Cossey, I think.
Yes, Kelly Cossey, and all of you all have my email, and you all email me all the time. which is wonderful. And please continue to do that. And I'm happy to connect you and make sure that you get connected to the right Kelly. It is Kelly Cossey. And I'm working collaboratively with Kelly on that work. So feel free to send me any information and I will make sure that it gets into the right hands. Thank you for that clarification, Dr.
And
Rob.
BHAAC members, this is Kelly. And just for the members of the council, we know how to reach you. So we have all of your emails. You will absolutely get outreach from me and Megan as we plan that. So don't feel like you need to take that extra step, but we're definitely going to reach out. But if you all will be thinking about the folks in your communities that should be part of that. So when we do the outreach, if you'll already be thinking about that, we'll be able, that'll help us to expedite how we do the planning and all of that. So Robert, thank you for asking that again.
You can visit me in Douglas County on your way to visit Robert in Pueblo.
Yeah. Well, we will stalk your Instagram if that's what it comes down to.
Watch me, Robert.
And be thinking of the good restaurants, you know,
Okay.
the like places to go, because I know Danette will want to know that also, as will staff. So thank you all.
Thanks, Kelly. Yeah, we don't have any fun on council here at all. At all. I love our council. Okay, so next we are talking about open positions and chairs. Where are we at, Megan?
Yes.
That's on you. Right? Am I handing this off to you now?
Yes, you can hand it up.
Take it away, Megan.
Thank you. All right, BHAAC, a few updates for you all. There are some open positions, as you all know, within our council. We had a few members that have moved on to other things along the way. And so we do have some open positions. We have started recruitment for those positions. So recruitment is open through tomorrow. So reminder, if there's anyone you know that would be interested in serving on either the Behavioral Health Administration Advisory Council or the Family Voice Council, recruitment is open until tomorrow. And we are actively doing interviews as we get applicants in. I can tell you that as of last Friday, we had 72 applicants for both BHAAC and Family Voice Council, and we are interviewing every single person that applies. And this has been a really beautiful process, really meeting some really incredible people. And so I feel very confident that we will add some additional wonderful members to our council for BHAAC, as well as building out the Family Voice Council and have members on there as well. And I do want to, I wrote it in my pre-HAAC or in my pre-work email to you all, but so grateful for those of you as Michelle and Danette had mentioned, we really appreciate all of you that have stepped up to help and volunteer to be on interview panels. I know it's a lot of time commitment, but really important to ensure that your perspective is at the table as well. And so I'm going to stop for just a minute because Caroline, I see your hand.
Yes, so I did send out an email. I responded to an email that, yeah, I'd like to be a part of the interview processing team, but I haven't, they're not going to be back till the 27th. So I just want to put it out there so that you know that I have interest.
Yes, and I have shared that, Caroline. And so you will be outreached. We'll let you know when we start to schedule more interviews. We started interviews already just because they're coming in so quickly. So to get ahead of it. And so some of them are in progress, but as we're accepting applicants through the 22nd, there will be lots more opportunity. So really grateful. Thank you so much for volunteering to help us out with that. So we are hoping that by the May meeting, we will have a full council and we will be able to vote in our permanent chair or co-chairs. into BHAAC during the May meeting. And everything is moving along on track. So I see that in our future. I feel confident that we'll be able to do that at the May meeting. And so I'm very excited for that. But if we do not have a chair voted in at that time, thank you, Dr. Rob, for stepping up to chair the May meeting. And Tasha, I see your hand.
How many positions do we have open on the council, like open for council members?
I will have an exact answer for you by the end of the day tomorrow. We still have a couple of BHAAC members who have not signed their letter of commitment. And so I'm reaching back out to them one more time. I want to give them that full length of time, hoping that everyone does stay on our council. And then I will have that exact number for you. And I can send that to you by the end of the day tomorrow. Thank you, Tasha.
Okay, thank you, Megan.
Any other questions about either one of the councils or the process that goes along with it? Okay. And I did, as you all are reaching out and sharing this opportunity with folks, please remember that we have made the decision that people can only serve on one of our councils because we really want to give the opportunity to as many folks as possible. And so, for example, BHAAC members cannot also be Family Voice Council members because we really want to have as many council members across the BHA as we can. And the interest is there. Having 72 applicants by the end of last Friday, I don't even know where it's at now, but I would imagine it's much higher. It's really exciting. People in Colorado, they want to be involved in this work and they want to be co-creating it with us. And I'm really excited for that. And then additionally, if you didn't see in the chat, I shared the link to the community engagement specialist, which is also included in the pre-work email that I sent out to you all last week. So please share. Michelle talked a little bit about those positions. And if you click on the link, there's the full details, as well as the regional map. And so there's 4 regions that we will be focusing. The engagement specialist will really be focusing on all of the underserved communities in those regions. And they will have special training to ensure that they're reaching out to those communities in a meaningful way that is collaborative and brings their voices to the table. And then I see a question. Okay, looks like that one was answered. Oh, there's a question of, can BHAAC and Family Voice Council members serve on both CDHS and BHA Family Voice Council? And so that question, I think Chelsea Hall is looking into that. And what we've been talking about is you can serve on different agencies. So you can serve on a council for one agency, but not multiple councils for that same agency. And that question is a little bit complicated because CDHS is the back office for BHA. And so I will look into that question and get some additional clarification around that question. So thank you for that question. And Tasha, I see your hand.
Is this going to, with this thing that we're rolling out with only one council, since I serve on the CDHS Family Voice Council and I'm also sitting on BHAAC, is that going to affect me because I term off on Family Voice Council in June? So I don't know if that's going to affect me between now and June.
No, you're good, Tasha.
Okay, thank you.
Any other questions about that? The other thing that I will mention is Family Voice Council meetings have not yet been established. And so we will let you all know that will be a collaborative effort to find a time that works for council members and BHA support. And Family Voice Council we are in the process of hiring an equity director who will be overseeing that council And then the engagement specialists that I mentioned will be collaborating and ensuring that each of their regions, that the needs within their regions are also brought to the Family Voice Council. And so it will be a group effort, and they will be supporting Family Voice Council as well. All right, so I already provided a chairs update. We are hoping to have a full council by our May meeting, and we'll then be able to elect volunteers for our BHAAC chair or co-chairs. And lastly, several of you have asked about bylaws, so just wanted to clarify that one more time. Within our policy and legislative division, we are hiring a boards and commission staff. And so getting close to selecting a candidate for that, which is really exciting. And that person will be tasked with ensuring that bylaws across all of our boards and councils are aligned. And they will be working to ensure that BHAAC bylaws are ready for you all to be able to vote on them. And so very much appreciate your patience in this effort and your patience in allowing the BHA to create alignment across all of our boards and councils as we continue to expand upon our councils by adding Family Voice Council. Any questions on that? Okay, that is all of the updates that I have for you all. As we are a little bit ahead of schedule, not to put you on the spot, Ryan, but would you be willing to move ahead and share your legislative update now? And then we can give a little bit more time to our presenters later this afternoon.
Yes, I am good with that. So I will dive right in. So I'm Ryan Templeton, he, him pronouns. I am the Policy and External Affairs Division Director with the Behavioral Health Administration. First off, one additional update to the boards and commissions position. We have an offer letter out as of this morning. So fingers crossed, the entity that, or the individual that we've offered to has wants the weekend to discuss that position with their family. So fantastic. I mean, even just the response from that individual with making sure that this is the right fit for the family, I think is a positive sign for us. And so really fingers crossed that that offer works out. With that, today is the 72nd day of the 120-day legislative session. So with that, we are in our last 50 days of the 2024 legislative session. Not that anyone's counting except me. May 8th is the last day. So there's a lot to get done before that May 8th last day of the session. A big thing happening right now, or really this week, is the Joint Budget Committee, JBC. So that's the committee that is responsible for making decisions related to what the budget all across all state agencies is working to balance the budget across all of the funding streams based on the latest Colorado economic and revenue forecast. So revenue forecasts happen every 3 months. The March revenue forecast is very, very important because that is the revenue forecast that the Joint Budget Committee uses to make those final determinations about essentially how much money the state and the legislature has to spend on the annual budget, which then turns into the long bill, which is the long bill is that massive bill that covers every state agency's budget, and including the Behavioral Health Administration. The long bill is due to get introduced in the House of Representatives tomorrow. So you'll see that, and that kind of starts the whole flood of where do we go? What are all those other special bills that we've been through? Yes, this is exciting, but then we're just waiting in appropriations. An appropriations committee, while they figure out how much money the legislators actually have the ability to spend and negotiate, and what bills become priorities versus less priorities. So That's why things are kind of slow, even though not really slow, but things are just stuck in Appropriations Committee. So the long bill coming out is a big step for what is happening over there at the Capitol. One thing, we are tracking roughly 30 behavioral health bills. Not all of those behavioral health related bills impact the Behavioral Health Administration directly. But just the reminder, and I think all of you know, the Behavioral Health Administration is responsible for creating that cohesive, coordinated, effective behavioral health system across all state agencies, all branches of government. So it's very important that we follow those bills and how that fits into our bigger vision of what behavioral health service delivery in Colorado should be for the people of Colorado. So with that, we'll make sure that in the minutes, we get the link to what we've been calling the Behavioral Health Advisory Council's 2024 bill dossier, which just puts those 31 bills into a document that gets updated routinely. So it's, if you want to use that, it's one link that continuously gets updated. So you just have to have that one link to see those bills. Every time a new behavioral health bill comes in, I will make sure that it goes into that document, so it's easy for folks that are interested in following along that way. The bill dossier comes with like, hey, here's the bill number, here's the bill title, here's the sponsors, here's the quick overview of what the bill does, and here's where it is, the status of the bill, right? It was approved in committee, or it's sitting in appropriations, or it's moved to the other chamber of the General Assembly. So that can be a resource. Do with it what you want. Yeah, if it goes into the minutes, it is public, right? So those are all introduced bills that are all public as well. So that is a resource for you all. So with that, I'll just jump into a couple bills that we're very excited about. Our agency bill, Senate Bill 1, to continue the Youth Mental Health Services Program, which is the continuation of the I Matter program. So that's that program that provides free therapy sessions to youth. It made it through the Senate. It is on to the House of Representatives. It is going to the House Health and Human Services Committee on April 2nd for that committee. So we will be down there in full support of that bill, moving it forward, because that's a fantastic opportunity for youth to get some therapy services if they are screened to need so. So big one for us, that is our one agency bill. So looking forward to seeing that move through. Another one that we are very interested in is Senate Bill 24-117, which is the Eating Disorder Treatment and Recovery Programs. So this is the bill that requires eating disorder and treatment recovery facilities to hold a designation provided by the Behavioral Health Administration to make sure that the services being provided in those eating disorder recovery and treatment facilities are meeting the needs of the people there. So it's really about health and safety of the patients receiving services for eating disorders, right? So there's been some pretty negative press lately about what service delivery in those facilities look like. So this is an opportunity for the state to become more involved and make sure that health, safety, welfare is the primary thing that people deserve when they're getting any sort of behavioral health related treatment. That is, like I said, this is one of those bills that's waiting in Senate appropriations, right? It passed through committee, and because there's a fiscal note attached to it, or it has money associated with it, or costs, it then goes to the Appropriations Committee, where it's just sitting in Appropriations Committee until that long bill, which I talked about at the beginning, starts to move. So that's one that we're excited about. Getting involved in that is a fantastic opportunity for people to receive appropriate care. Another one, House Bill 24-1045, which is the treatment of substance use disorders. This does a whole bunch of things within that bill related to substance use disorder treatment initiatives. One thing we are very excited about, it creates a pathway for individuals to access Medicaid while in jail, right? So right now, Medicaid turns off. So then there's this transition for someone leaving a carceral setting back into the community, that it may take a little bit of time to actually get the care that those individuals needs as they transition from one setting to a community setting. This would allow healthcare policy and financing to seek that waiver to add to the Medicaid state plan to actually provide the the access to Medicaid while in individuals in that setting. So it's an easier transition out. We are excited for that. I think that's a major step for Colorado in making sure that there's a continuity of care for people transitioning to different settings. We're eagerly looking forward to that. There's some things that still have to happen. That's another one that is also waiting in appropriations, right? So we will see this flood of activity really kind of starting tomorrow and into next week, and these last few weeks of the session, or really the last month of the session, as we come to the end here. One that we're excited about that passed through the committee of reference yesterday on a vote of 11-0, which is fantastic, is House Bill 24-1360, which is the Colorado Disability Opportunity Office. So this is an office that serves as a resource for contact for state agencies, private and nonprofit organizations, and the public concerning disability issues in Colorado. This ensures that the goals are really there for full societal inclusion for individuals with disabilities, as well as meeting with stakeholders and entities around the state related to anything, recommendations related to how to best include everyone into decisions making of the state, and kind of that restructure of disability related issues. I see this as a massive call out to what the structure of the Behavioral Health Administration is, because I read the bill, and maybe this is me personally, I read that bill as they took the model of the Behavioral Health Administration and said, this is a fantastic model to create a single entity that is responsible for a thing. So that office would be responsible for really creating the disability opportunities and cohesion within disability opportunities, just like the Behavioral Health Administration is responsible for all behavioral health services in Colorado. So excited about that one. Those are just a couple of the ones that I highlighted. We'll make sure that, in the minutes, we have that link to the bill dossier. So you can have that for your reference. But with that was my legislative update. I probably talked really fast, as I always get called out for, so I apologize for that. But this group makes me excited, and thank you for allowing me to participate. I love this energy.
Ryan, as soon as I went off mute to slow you down, you automatically slowed down, so I didn't have to call you out today. Thank you for the update.
Yep.
Thanks, Ryan. We are going to go to break. We are going to take a 15-minute break. It is 18 after. My math brain puts us back at 33, 34 now. We just went to 19. So at 34 after, we'll all return. 15-minute break.
Thank you, Raquel.
You're welcome. Deep breath in. Exhale out. Ooh. I'm going to bring some self-care into these meetings. Watch out now.
Thank you for that, Raquel. We all need a reminder to breathe sometimes.
I'll gladly remind you to breathe. All right, moving forward. We had our legislative update prior to break. So now we are going to do our performance monitoring hub. Jordan.
Awesome. I will go ahead and kick us off. First of all, good morning. Thank you so much for having us here to talk about such an incredibly important initiative that BHA's data and technology teams have been very hard at work on, creating BHA's performance monitoring system, also known as Performance Hub, which is very exciting. Just in case we haven't had the opportunity to meet yet, hello, my name is Jordan. I use she, they pronouns, and I am BHA's Director of Data Science. I'm also very excited to introduce you all to a good friend and trusted colleague of mine, Ria. Ria, would you like to introduce yourself and kick us off?
Yeah, hi everyone. My name is Ria Singh. I use she, her pronouns, and I am the project lead for the Performance Hub, which I'm very excited to talk to you all about. And I don't want to take up too much time, and I want to make sure that there's some time for discussion and Q&A for those of you who are interested in helping us make this great, which is our main objective. But before I talk about how we want to do that, I want to sort of tell you what Performance Hub is going to be. Next slide, please. I'm not sure who the slide queen is, but slide queen, please. Thank you.
You
So we're gonna-
I was gonna say, you actually just have control of the slides, Jordan and Rhea, you both do. So you can advance your own slides today.
Okay, thank you. There's a little bit of an echo on my side. If you don't mind going back one slide, I just want to do an overview of what we're going to talk about. So we're going to talk briefly about the Performance Hub, and happy to come back to this and talk through definitions if that's useful for anyone. And then talk about what we're interested in seeing if there's any interest from this group in participating in our metric refinement working group, and then be really specific about our ask of you all, and then get into any questions that you might have for us. Next slide, please.
Rhea, can you hear me okay? I know Marina was really echoey, but what she was saying is, I think either both of you or one of you should be able to, if you hover on the screen in the bottom left, you should see where you can advance the slides.
That is very fancy. Thank you so much, Marina. I see the arrows. Okay, so I'm going to get started with an overview of the Performance Hub. So Jordan and I and a couple of lovely colleagues are deep into the weeds of developing and establishing a performance monitoring system known as the Performance Hub. Our objective is to track capacity and performance of all behavioral health providers. I will say that this is a legislative mandate that we are sprinting to July 1st to launch this, but what we're really excited about is it's a really unique opportunity to provide transparency to the public, not only on sort of the state of how providers are working, but the state of BHA as well. So sort of put the mirror on ourselves and say, here's what we're doing, and here's how we want to get better. It's a really cool opportunity for us to inform changes needed not only within the larger ecosystem, but within the state itself. Part of what we're doing with this work is collaborating across different agencies within the state to ensure that this is informative and actionable, but also different communities that know way more than us about what we should be looking for in terms of not only quantitative data, but qualitative insights. And that's where we are very privileged to be among experts here to talk a little bit about this. Next slide. Slide queen. All right, next slide to myself. So this is an overview of the architecture that we've actually already put together and are excited to play around with and make even better. So we are at a very high level taking a number of existing data sources, as you'll see in the bottom rectangle. And we're doing some fun data sharing agreements with legal teams and getting all of that data together into what we call a data warehouse. Within that data warehouse, we're doing some fun engineering magic to make these data sources talk to each other so that we're able to look at a single provider or a single client across different data sources. So to get a more holistic picture of what's going on with services, specifically access to care and quality of care. From there, the thing that the world will be able to see is a set of public dashboards that will be published on the BHA website. This is the thing that I think people will be most interested in. Jordan and I are self-proclaimed data nerds, so we care about what's happening in the data warehouse, all of the engineering stuff. We also obviously care about the public dashboards and are excited to talk to you all about what that might look like. And specifically what metrics we should be paying attention to. So I can go deep into any of this, but I think the big ask, and I keep forgetting that I have the control here. Oh, sorry, before I get into the ask, wanted to sort of share again that we are sprinting towards a July 1st legislative mandate deadline. So we want to make sure that we meet that mandate, but also use this opportunity to create something really valuable and informative. So we are, again, knee deep into metric design. So we've put together like a repository of what metrics we can possibly look at, And now we're putting together our working group of experts to weigh in on these metrics and look at them and say, okay, this makes sense to look at, this doesn't make sense to look at. This will make sense to look at if we can improve how we collect that data, if we can do it in a more equitable way, for example, and that's something that we will build into a phased approach. This working group will also help us design the dashboards. So we'll have some experts who build the dashboards, build mock-ups, which are essentially just like the outline of a dashboard, and it'll show it to the working group, and the working group will say, this looks okay, but this is not necessarily accessible to this community. So again, bringing the experts together to make sure that we're building something really useful. And then Jordan and I and the rest of the engineers will do our thing. And then MVP launch is just one milestone. We're really excited for this to be something that BHA continues to iterate on, or continues to build and make better past July 1st. I think that's what we're especially excited about. So that's the roadmap. So the working group, as I mentioned, to begin, is a metric refinement group. So we have a massive spreadsheet of potential metrics that we can look at in this first iteration. So we're really looking to put together a working group of folks who can help weigh in on what we should specifically be looking at from those metrics for July 1st. That group, again, will help us also design these dashboards. And we're hoping to continue to work with this group over the next few years as we continue to iterate on this and choose metrics to build this out further. In the immediate term, we're planning on starting these meetings late March, so potentially next week, early April, and into the end of May. And we expect that these meetings will take approximately 6 to 8 hours total for participation. And we are going to do our best to make sure there's no homework for these working groups. So folks are just expected to be present during these calls and bring their expertise and insights there. So our ask of this group is to nominate a representative to join this working group for our July 1st period. So for the next few months, this could be potentially a rotating position and/or invite us back to present out on the working group's outputs. We know it is a lot to ask to dedicate time to a working group, and it might not be something that folks can commit to. What we can commit to is coming back and actually presenting out what the working group does find and using potentially spaces like this to gather feedback on the metrics we select, on the dashboards that we create, things like this. And that's it. I think my last, oh, yeah, that's my last slide. Any questions on Performance Hub? Happy to answer this question in the chat. What's the estimated time commitment for the working group? So over the next, I'm going to say from April to the end of May, the time commitment is 6 to 8 hours. We're expecting those to be 1 to 1.5 hour sessions. And again, no homework outside of those sessions. I don't know who had their hand up first, so I'll let you just come off mute in the order that you raised your hand.
Renee, you want to go ahead? Me? Okay. I just want my question for you guys. I just want to find out, are you guys making sure that this is quality data instead of just quantity? Because when it comes to data, you got your garbage, you got your quality, and we want to make sure it's quality. So because garbage in, garbage out, quality in, quality out.
That's such a great question. This is the reason Jordan and I care so much about this cylinder in the middle. So what we are focused on right now, and part of what informed the massive spreadsheet of potential metrics that we put together, is what data is actually not garbage, what data is usable data. So such a great point. We have developed a framework that we're going to be publishing on April 1st. I'm not sure if we were going to announce that or not, but on April 1st, we are going to be publishing a framework, and we talk a bit about data quality and how really the challenges with data quality are how we collect that data. So are we manually sort of collecting that data or not? Why is this data garbage if it is? So we have some ideas around how to improve the quality of data, but for this system, we are prioritizing the highest quality data. And I will say that that does constrain what we're able to present out and look at, because frankly, there's a lot of garbage data out there that is it could be useful if it wasn't. I'm saying garbage too much because you started it. You said garbage and now I can't stop saying it. But I think you get the gist of what I'm saying. Did that answer your question?
Absolutely. Absolutely. Thank you.
I'd love to add a little bit to that if I can. I think a really exciting piece as we think about Performance Hub is it's not necessarily just the end dashboard that is available for public use. There are components where we want to provide the appropriate documentation and specifications that says, this is how this was designed, this is how this was calculated, to ensure that there is a lower possibility of folks interpreting metrics in different ways. And I think that transparency and working in the open is a standard that I'm really, really excited that our team gets to demonstrate, especially through the lens of co-creating this system with groups like this. So great question.
Okay, I have a question. With this new dashboard and I think you said an app and different things that you're doing, is it being tested with someone who is blind or visually impaired to be able to not only have it be accessible, but also usable?
Yes, that is part of our roadmap, and thank you for flagging that. I think in addition to those who may be visually impaired, we are looking to the experts to advise on additional considerations for accessibility. So I think for July 1st, it may not be feasible to explore, for example, like different languages, providing dashboards in different languages. But that's another example of, expanding this to be most accessible to those who could find this data useful. So thank you so much
Are
for
you having it
that.
actually tested by someone who?
Yeah. So we are going to have a user acceptance testing period, and we are planning on having someone who does have that kind of lived experience be part of that effort.
I have a question. When doing equitable behavioral healthcare all over the state, one of the questions I ask is, number one, what does inclusive and culturally humble and equitable data collection look like when you're working across the state of Colorado? And also, I understand that we are collecting always on the people coming in the door. I'm also curious to see what efforts are being made to collect data on service providers. We can see inequitable referrals when we also take in account those who are providing services. What is the demographic makeup of those who are providing the services, also not just those who are taking in those services? In some areas we've seen where there can be disparities between those who are offering the referral. For instance, white, predominantly only referring white individuals to a majority of services and not inequitable to those who are of color and culture and indigenous backgrounds. So I just want to know if you guys have thought about that when you're doing data collection.
So this is such a great question and perspective. Thank you for sharing. This is exactly what we're hoping our working group can provide expertise on. I, as an individual, have a lot of thoughts on inclusive and equitable as a person of color, as a person with identities that I think are on the diverse side. I think I have personal opinions, but we want to bring a working group together with expertise and relevant representation. I will say,
well, and if you're the only one, then that could be a challenge, right? So like it'd be different if there's 7 of us of color at the conversation, having this conversation, then oftentimes we're all alone in those conversations. It gets kind of hard to have our voice held. So I appreciate you being in it.
I appreciate you sharing your perspective. I think this is why the working group, having a representative from this group and potentially a rotating representative, and just advice to our team on other communities that we should be collaborating with as we think and answer this difficult question around what does it mean to do inclusive and equitable data collection? Because while I have thoughts on it and others who are going to be building these systems have thoughts on it, we really can't paint that picture alone. I don't think I answered the second part of your question.
No, you did. You did.
Okay. I'm not sure who's next. I think Cameron.
I'll go next. Yeah, Cameron Disfellow. I'm just curious if there's any conversations about adding cost of care or affordability or typical accepted insurances or anything like that to your domain one in those metrics, because I could see that being, being of interest to the public.
And it sounds like the baby's also interested in that idea. So I want to kick it to our Director of Data Science, Jordan, to weigh in on maybe one or two of the metrics that we're looking at. Sorry, I'm very much putting you on the spot to answer a couple of metrics that we might be looking at around this. But yes, we are looking into data that's available to tell part of that picture. But what we do know is that data that tells us this picture doesn't tell us the full picture, if that makes sense. Jordan, anything to add?
Yeah, I would say, so we talked about this a little bit in the context of the roadmap. We have a series of metrics that we are deeply considering for July 1st in order to meet our legislative requirements. So for example, we have had a number of different conversations with HCPUP talking about what are the metrics that they have gone through and vetted in alignment with some of the work groups with the RAISE. Where is there opportunity to align to ensure when we are comparing across systems, we do have some apples to apples, but to the points raised here in a number of different questions, this might not necessarily reflect the entire experience of someone seeking care or receiving care. So I posted this in chat, but I think this all really speaks to the value of having an iterative development process where we can say, hey, let's post these metrics. Let's see how this feels to folks. What are we seeing reflected of the population that we're digging into? What are we not seeing? Who is included? Who is excluded? And I think that is especially relevant when we dig into access to care. So I think it was mentioned, we know the individuals that are able to get into care. We can say, you had a behavioral health crisis. We see you found the right door. We see that you found follow-up care. But what if you don't know that door exists? How do we track that step before? And I think that's where a group like this has such a wealth of knowledge that we want to tap into to understand what are the appropriate mechanisms that we can lean on to start developing metrics that can capture that in an equitable and non-burdensome way, because we do want to respect that we're not creating additional burden or making folks feel uncomfortable that we are collecting data at a point where they just want help. We don't want to add burden to that. So I really, really love that question, and all that to say, a lot more to come.
I think you can tell by our questions and comments how exciting it is to see this work in progress. So thank you, Jordan and Rhea, for sharing this work. A couple of thoughts and questions. So I'm part of a national working group looking at child behavioral health metrics. So I guess that's the other piece. So coming from the child health care world, quality is, as Tasha mentioned, there are many domains of quality. They are very clearly defined. Is it safe? Is it equitable? Is it effective? Is it timely? Is it efficient use of resources? Is it affordable, right? Is it patient and family centered or client and family centered and culturally responsive? So all of those domains, there are very specific operational definitions. And what's amazing is you will have access, right, to lots of public data across hopefully lots of different departments and agencies, and hopefully in that sort of like, if we look at partnering across data sources, for me in child health care, like I'm also really curious about outcomes, right? And those outcomes need to be outcomes that matter to kids and families, to their communities, to their schools, right? And so even coming up with those sort of longer term, really meaningful outcome measures, and not just like how many kids are in care. What does that care really look like? Is it acceptable? Is it responsive? Are they getting better in the ways that matter to them? I think we would all love to be part of that conversation. And, will the educational system data and the child welfare data and the justice system data and the healthcare data and the employment data future forward, will those data systems be able to talk with each other so that everyone in Colorado has access to this sort of transparent dashboard that you all are creating now? So any help that you need from us in any of these realms, I think you definitely hear that we want you to come back, and however we can help in the stakeholdering and work groups, I think would be really helpful too.
I think we are a minute over our time. So thank you again so much for having us. And again, this is sort of the ask of the group. It sounds like folks might be interested. So again, would love to have a representative nominated from this group, and then we'll come back and we'll talk more about this stuff with you all. Thank you.
I'll jump in really quickly and just let all of you know, BHAAC, that I have this also on our agenda for our May meeting tentatively. And if not our May meeting, then the next meeting after that, just so that this is ongoing work and we definitely value your input. And today's purpose was really for you all to get just an overview of it, and then be able to nominate a representative to join this really important work.
So Megan, this is Danette, and I just wanted to hop in and say to Jordan and Rhea, as the commissioner, you have a geek with data. And so I am ecstatic to see what you're doing. And I wanted to know, what platform for your data warehouse are you using?
Go ahead, Jordan.
Well, first of all, can I just say, we have another data geek. I love it. Welcome to the club. We are using the platform called Snowflake. It houses, we are moving towards housing.
Okay.
Oh, you're familiar? Awesome.
I'm very familiar with Snowflake. Wonderful, wonderful. I just want to say that I've seen today, I am very excited. I hope that you will get on my calendar so that we can talk more in detail about where the data is going and where the dashboards are going. I'm always a little nervous about public dashboards, but I think that as long as we define it and define the outcomes, and we have a process to always update data and make corrections as part of the rollout. And I know I want to talk with you a little bit about rollout. That will meet my need, but I was very happy to see the presentation today. And I too am a data geek. As a commissioner, I probably could go on for hours to talk about what's needed. So I look forward to you contacting me directly and getting on my calendar. Thank you, Megan, for the time.
Jordan, what are next steps with getting someone nominated? Would you like them to reach out to me directly and I can connect them to you? I just want to be mindful of time as we have our next presenter ready to go as well.
Yeah, absolutely, Megan. If you would like to handle the communications, then just let Rhea and I both know, and then we can reach out to any interested folks with next steps. Thanks again for this time.
Perfect. Thank you.
All right. Now we're going to move forward on BHA care coordination programs. Gwen?
Thank you, Raquel. Good morning, everybody. My name is Gwen Gommond. I am our Interim Director of Care Coordination at BHA, and I go by she, her pronouns. I see a lot of familiar faces today, so for some of you, you'll be hearing about our care coordination programs for the second or third time. But I do have kind of a long presentation time set aside. So what I would like to welcome everybody to do is to feel free to come off mute and ask questions or put questions in the chat as I move along, because some of what I'll be covering is kind of complex. And again, I want to make sure that we don't lose any important questions in the shuffle. This morning, I will be covering care coordinations programs, including Emergency Department Assistance Program and our involuntary civil certification programs, as well as the training that the care coordination team is responsible for. So I'd like to start this morning with Emergency Department Assistance. This program became active January 1st of this year, and it was driven by changes to 2765 statute. This program is staffed by our care coordination navigators. So we have 3 bachelor's level mental health professionals that run the program every day, Monday through Friday. And then we also have our care coordinators who are our licensed master's level therapists who advise, and then we also take on call for this program. So let's start with our statutory mandate that drove ED assistance. The statutory mandate was a revision to 2765-106, section 7A and B. What this did was that it allows emergency services facilities, which are basically emergency departments, to contact Behavioral Health Administration when they're not able to find appropriate placement for anyone who's on an involuntary mental health hold. So what happens when you're on an involuntary mental health hold for 72 hours and you still continue to meet criteria is that often that hold has to be, a subsequent hold has to be placed. So really the rationale behind this is to help people not languish in our emergency departments and continue to be on holds for longer than 72 hours in that initial assessment period. So what this program does is it allows for the emergency department to request assistance at any time to secure an appropriate placement. But that is with the expectation that the emergency department staff and the evaluator have already tried to place the person in all the appropriate placements available to them and have not been able to do so yet. We ask that the EDs contact us by hour 48 if they're anticipating having to write another subsequent hold and if they want our help. But there's also a separate piece of this that is mandatory for emergency departments. And that piece is that the emergency department must inform the BHA and the appropriate court whenever a person is placed on a subsequent hold. So once you write that subsequent hold, there's a mandatory notification that comes to us and it also goes to the court. And for EDs that aren't sure who the appropriate person is to contact in their area or where that court contact is, we provide that information when we're getting the notification into us to ensure that EDs are enabled to let everyone know per statute. And this is a little bit antiquated, but we've done more than 30 ED assistance requests. So that means that we've gotten requests, not just notifications of a subsequent hold, but asks for help. And of those asks for help, we are typically successful about 90% of the time. So in acting as a second pair of hands for that bed search, we've been pretty successful. So how does this program operate? The care coordination team, which includes 3 care navigators and the 2 care coordinators mentioned before, is available 7 days a week, including weekends and holidays. So every day of the year from 8 a.m. to 8 p.m. You can call us at the number listed here, that 303-947-5076, if you are in an ED and requesting assistance, or you can email us at our care coordination email address. What we do is assist EDs in finding inpatient psychiatric placements by calling all the appropriate facilities on their behalf. So this doesn't mean that we're taking clinical packets, and it doesn't mean that my team is making a further assessment. It just means that we continue to check for capacity over and over again until that person is placed. Even if a subsequent hold has to be put on, we still continue our assistance until they are placed. And for all you data nerds, I have listed here what things we are tracking. We're tracking some things that are part of the legislative mandate, and we're also tracking some things that we find valuable. So our team, when we get an ED assistance request or notification of subsequent hold, are tracking how many subsequent mental health holds, emergency mental health holds are placed. What was the presenting concern? So that means, was this person a danger to themselves, a danger to others, or gravely disabled? The reason for the M1 hold, which can be seen as that same thing that I just mentioned, but also what is the diagnosis or what was the scenario? So between that presenting concern and the reason for the M1 hold, we're trying to capture what was driving this emergency mental health hold. Were attempts made to find placements that met the person's language, identity, accessibility, and cultural needs? Were those attempts made? And then when and where a placement was secured. We also track our contacts with emergency departments. So we track which emergency departments we contacted on behalf of someone who is on an emergency mental health hold, and then what types of issues were causing that placement to be refused. So was it that the facility was at capacity? Was it that the clinical criteria were a mismatch, or it was inappropriate for some other reason? And we keep track of that as well, although that is not part of our legislative mandate. So I wanted to provide scenarios for use of any of our care coordination programs so that it just brings a real world example of how this plays out. So in this particular scenario, we have that a 13-year-old has been placed on an M1 for danger to herself. The emergency department clinicians cannot find appropriate placement, as all inpatient facilities that can take a child of her age are at capacity. So we would ask that the ED would contact BHA at hour 48, and then they contact us. Then our BHA team takes the information that we've gathered and contacts all the appropriate facilities according to the admission criteria. We continue to do so every 4 hours until a placement is made and capacity is found. Unless a facility says, you know what, our doctors are rounding by noon today, so call us back after noon and we should know more about whether or not we'll have an open place for this person. So generally speaking though, if facilities are at capacity, we don't consistently continue to call them because we know that there are factors within the facility that keep them from having a change in capacity during that time. When there's a subsequent M1 written prior to us or the emergency department finding placement, then ED will inform BHA in the court, and we can help that ED with a list of appropriate court contacts for them to use to let the court know. If BHA, our care coordination team, finds a facility with capacity, we let the ED know right away, and the ED completes the placement process. So they send either the whole clinical packet or a refreshed clinical packet and arrange for transport. Any questions that came up in chat about this process? Okay, I'll continue to move forward.
I think Tasha has a question.
Okay.
When it comes to the beds and stuff in the departments, can I ask why the emergency room departments or the hospitals do not have a psychiatric unit?
Why do
to help out with this issue? I'm just the only time that I was in psychiatric stay was in Pittsburgh, Pennsylvania. And instead of going directly out to a facility, they had a psychiatric unit. And that's where they did like the 3 days. And then if you needed more time, that's when they found you a bed. Why isn't Colorado kind of like modeling that yet?
That sounds like an awesome idea if we could proliferate that throughout all the different hospitals in Colorado. There are a couple of them that do have an embedded psychiatric unit that, you know, their EDs can refer directly into, but that's relatively rare in our ecosystem. In terms of how that happened, I don't have a good historical context for that. But I think that it would be better patient care if we did, definitely.
Thank you.
And then Robert?
Yeah, so my question is, I understand, I think this is great. I think it's the second pair of hands. Most everybody knows how to do what you're talking about. When you said they set up, the thing that threw up a red flag in my head is when you said they set up transportation. I could tell you right now in our rural communities, in our smaller communities, that's not helpful just to say they set up transportation, because there's nothing in those communities, and that includes secure transport. And I could tell you right now, the best way to get on the bad side of AMR is use them for transport. And then they just hate your agency forever. So is there something that's going to be done to help with transportation? Because that is a big issue in our rural communities, in our areas. There is nothing to transport. There's no way to transport. Then our providers take on the liability of putting someone in a cab or in something like that. And then it's probably super inappropriate anyway. So will the BHA be helping with secure transport? That is a huge issue. Like this stuff that you're talking about, it is a second set of hands, because most of the time we've already gone through this. What will be done to help with transportation?
Thank you so much for highlighting that issue. I can say, having worked mobile crisis response and managed teams in Garfield County and Eagle County, which are quite rural, that I'm quite very familiar with the issues related to getting someone who's on an emergency mental health hold to their appropriate placement from a rural community. I am not aware of, we're aware of the issue, but I'm not aware of a work group that currently within BHA that is addressing this, although I know that healthcare policy and finance does have some new rule around that. So what I would like to do, Robert, is do some internal checking and get back with you on, which of our teams has that as an initiative. Because we also have a team within BHA that focuses just on crisis. And Ryan, Ryan Templeton, I don't know if you may have an update on that or some awareness of who within BHA is working on that issue now. But if we don't know, we'll get back to Robert at another time.
Yeah, if I may, this is an absolute opportunity for us to make sure that our systems are actually coordinated with each other, right? I don't think there's been a whole lot of conversations within even just the creation of the BHA is how does actual involuntary mental health care fit into our larger structure that we're trying to create and people have access to. Dr. Archuleta, you brought up a fantastic point where it's, hey, yeah, we can have all these services if they're not accessible because there's not transportation. Good luck. So we have to address those things. And I think this is the exact right group to talk through this stuff. This is also why I'm excited about the boards and commissions coordinator, because this is a conversation also happening at the Mental Health Advisory Board for Service Standards and Regulations. That is that advisory board for 2765 specific. So we want to make sure that we have a coordinated and cohesive effort between an advisory body like this and the advisory body like that. So we are being consistent with each other about putting all of the power and energy behind a specific thing like this. I think is very, very powerful that can move things in the right direction. We have specific requirements within our crisis system to make sure that there is a coordinated approach to how secure transportation is utilized. I don't think we've done a very good job with what does that actually mean and how does that actually impact people. I think an opportunity with what Gwen's team is doing is getting the full scope of how many issues there actually are, how many holds are actually happening, where are the barriers, and the subsequent hold is needing because there is maybe not necessarily a bed isn't available. We can't get them there, right? So I think there's some nuance to all of those things as well, which is, fantastic question. And I think we're in the right spot to get to the solution.
Yeah, I just want to say thank you, because we go above and beyond to find providers for transportation. And then, we kind of leaked some of our providers at a meeting. And then the last time we called them, they said, it's kind of your fault. We're too busy to help you right now. You gave our number out. And so now every time we find somebody new, we're like, hold on to it, don't share. But I also want to say, Ryan, I love that you talk fast. And if you ever want to join a hip hop band and speed rap, I'm down to like work with you.
No, and I want to second that. Like, I literally, while we're in this meeting, I'm getting a call from this exact situation on a youth client stuck at Zebulon Pike who needs to be released for treatment. Now we've got funding to get him to treatment. Nobody can get him outside of that space and into where he needs to go. So this is an active thing happening like right now. And so, you know, then I have to get transportation insurance, which isn't covered on anything that I can get reimbursed on. And how do we do that? Right. So and this is a 16-year-old kid that needs support. So, and we don't have an answer other than put him in an Uber. Like we can do better as Colorado than that. We can get better than getting an Uber and hoping our clients make it from one point to another. It feels like, especially if you're in a rural community, it feels like a slingshot. So I got sober in a community with the city and all this access, and you slingshot me back to community that has nothing and can't help me and get me resources because we don't have transportation. And I live in Douglas County, so that doesn't even matter. Like, it doesn't even matter the city. They don't even have public transportation. Even in Douglas County has no public transportation, you know, and if you go south, it just gets less. So, you know, it is really an issue, even active today.
Thank you so much, Raquel and Robert, for bringing that up. Robert, I'm a little hurt that I didn't get an invitation to join the hip hop band, so I'm going to speed up now and see if I can get myself that invite. But no, all kidding aside, I really appreciate your feedback, and that's exactly why I wanted people to come off mute while I'm talking about these things, because this is our opportunity to surface these types of issues. So thank you both. I'm going to move on now to our involuntary civil certification programs that'll be run by the care coordination team. Just to set the bar for anyone who might not be familiar with that process, an involuntary civil certification is a court-ordered mandate for mental health treatment on an inpatient or outpatient basis. What makes it different from an emergency mental health hold or an M1 is that it lasts for a longer period of time. And there are a lot of changes to the legislation that governs these involuntary civil certifications that becomes active July 1. So these programs are in support and providing care coordination to support those changes. These programs are run by the BHA team members who are called care coordinators, and they are on my team. These people are, myself included, licensed professional counselors or licensed clinical social workers in the state of Colorado that will be providing care coordination and connection to services in these programs. I'm posting a timeline just to show some of the activities that are happening for both of our civil certification programs between now and July 1st. So I did want to highlight the most important thing that I think is happening along the lines of these programs is that we will be conducting trainings for judicial and for providers who are 2765 designated that work with certified individuals, starting towards the end of April, moving into May and then June. And then we'll have ongoing training support for how to access these programs within our office hours structure after July 1. So within care coordination programs for certified people, we actually have two sort of distinct programs for different types of populations. The first one I want to talk about is care coordination for persons adjudicated as incompetent to proceed that meet criteria for short-term certification. So starting on July 1st of this year, BHA has an expanded responsibility pursuant to House Bill 231138 and then Colorado Revised Statute 2765-108.5 to provide care coordination for people who are ITP or incompetent to proceed with misdemeanor charges or who the court feel are appropriate for this program and have a petition pending or on an involuntary short-term certification. So our BHA, when these individuals are identified by the court, and usually the scenario is that this person is likely in jail at the time that the court identifies them. BHA care coordinators will assist with placement when there is a petition pending for a short-term certification. So we've identified that this person is eligible for a short-term certification, meaning that they have traditionally not been successful in voluntary treatment modalities, and that their involvement with the courts was related to their mental health issue. So BHA care coordinators will assist with placement either inpatient or in an outpatient setting, and then we'll continue to follow that person while they're certified to make sure and receive treatment updates from the providers, and basically make sure that that person is at the right level of care and has the proper support. And again, the overarching goal for this program is to facilitate the person's return to voluntary treatment with the proper supports as soon as we can, and prevent the person from cycling back through involuntary treatment or any sort of criminal pathway due to their lack of support. So here's a scenario. A person who has a history of serious mental illness is contacted by peace officers, resulting in a nonviolent misdemeanor charge, and is found to be experiencing psychosis. So OCFMH is likely going to be the one who performs a competency evaluation on this person. OCFMH is our Office of Civil and Forensic Mental Health. And that they result in this person being adjudicated as incompetent to proceed. Then a professional person will evaluate the person who's been identified as incompetent to proceed and see if they meet criteria for short-term certification. Then they will contact BHA to coordinate care. And that means that we're going to find a placement for this person, either inpatient or outpatient. BHA will continue to follow the person, receiving updates from providers until the person can successfully return to voluntary treatment with proper supports. BHA will follow the person even when the charges are dropped, and while they remain certified at any level. So if they start here with court involvement, even after that court involvement is no longer happening, we're going to still continue to follow them and make sure that they don't fall through the cracks. I'm gonna keep moving because I have a feeling we might have some questions about these, and I want to make sure that I get through all this content, and then I'll take some questions. So the second program that we have in place is care coordination for people who are going to have their certification terminated, transferred, or allowed to expire. So the legislative mandate for this is that BHA has expanded responsibility to provide care coordination to people on terminated certifications pursuant to House Bill 22-1256 and Colorado Revised Statute 2765-108. What will happen, or how this will work, is that providers will report terminated, transferring, or expiring certifications, short-term or long-term, inpatient or outpatient, to indicate what the continued care plan is based on a checklist. So they'll have a reporting form and they'll say, this person's certification is changing, it's terminating, it's transferring, it's expiring. Here are all the things that we've done to ensure proper continued care and support. Providers can also say within that same form, look, we know that we can't coordinate proper supports for this person, so we need your help. And that also comes to us as the care coordination team so that we can see that a provider's asked for our assistance in creating an appropriate and sufficient continued care plan. BHA will review the plans like they're submitted in the form. If they seem insufficient or if a provider requested support, then we'll meet with the provider, create a summary of needs, and provide care coordination according to those needs. Again, the goal here is to ensure a smooth transition to voluntary treatment with adequate supports in the community. And I'm seeing a lot of hands go up, so I will move through the scenario and then start to take our questions. So, terminated certification with insufficient continued support scenario. So a provider is terminating a certification for a person who's been on an involuntary civil certification for more than a year, and that provider indicates they have not made an outpatient therapy appointment or arranged for ongoing medication access and psychiatric support when they're filling out the terminated certification form. In that case, a BHA care coordinator or a contractor that we're hiring to do this work will reach out to the provider and arrange a staffing. Then our care coordinators and provider staff will identify the barriers to care and create a summary of needs. Then care coordination will be provided according to that summary of needs. Once the person is engaged in outpatient supports, providers will be asked for follow-up information to measure continued engagement at intervals for the following 12 months. So we'll probably end up looking, and although this program is under development, so I'm not saying this is exactly how it will work, but might look like, are they still engaged at 1 month, 3 months, 6 months, and then 12 months in their outpatient treatment. Court records will also be scanned to identify if a person who has received care coordination has been placed on another involuntary civil certification within 12 months of that care coordination activity. Okay, so I saw a lot of questions. So Tasha, can I address yours first? Because I see you there at the top.
Yes, when it comes to the criminal justice system and mental health and determining if somebody has a mental health issue to go into and how to proceed with that, it starts at law enforcement. And that's where, because to not get, it just happened to me last year. I got falsely arrested on no charges, beat up. I have a traumatic brain injury. I got arrested. I told the cops that I had disabilities and a traumatic brain injury, and I didn't receive any care at all. Like nothing was done. And when I brought that up to the courts after having to bond out of jail and be my medical needs neglected, you know what I'm saying? With that, I told the judge, I brought that up in court, and then obviously there were no charges and it got figured out. So it starts at law enforcement because our jails are overpopulated with just people accused of these crimes and not even know if it's mental health, and then they're being neglected. So I'm just wondering how the state is going to implement that into a county level before it's the state level, and it'll eliminate population jails and our court system.
Thank you for bringing that to our attention, Tasha. And that sounds really difficult. I'm sorry that happened. But I will say that within our statewide programs division, we do have a team that works on crisis and co-response, and is doing their best to make sure that throughout the state, people have access to crisis response teams that include a clinical component to them. But BHA is currently involved. And Ryan, you may know of other intersections as well. And I keep tapping Ryan, guys, because I'm somewhat new in my position, although I'm learning fast. And so I want to make sure that we provide a really cohesive, comprehensive answer to all of these questions.
Yeah, and with that, Tasha, thank you for being vulnerable, bringing that stuff up. I mean, this just shows that it's the exact right people on an advisory body like this. I think there's an opportunity for us within the call of what the BHA is responsible for is also training certified peace officers and how to identify what behavioral health concerns look like. So we can start to shift where do people actually need to go? And it's not the criminal justice system, right? There's a lot of work that still needs to happen with that, but to me, we have the authority there. It's the BHA, and through BHAAC is like, how do we start to actually utilize the authority that we are given to do these things? Which I think that's a prime example of this. We have the ability to train law enforcement. This is the opportunity, and this is why it's also exciting to have a leader such as Commissioner Smith jumping in here. Is how do we make sure that we're working with judicial? How do we make sure that we're working with the post, the peace officers standards and training, which all peace officers have to go through? How do we make sure that we are getting our stuff into the training mechanisms that law enforcement utilize? So it's not just like, oh, BHA is over there telling us to do something, when actual authority comes from the post, the peace officer standards and training. So making sure that we have those connections to the right entities to get to the training that actually law enforcement will follow and see as their authority piece. So those are some of the pieces that we're working on internally. And so both between an advisory council like this, as well as I've plugged a few times, the 2765 board is definitely there with and then ultimately, how do we get to a spot where we're not relying on law enforcement as that contact in the community, which is eventually what we're going to hopefully get to. But right now, law enforcement is one of those folks that will go in most settings to be there. So we have to balance what is the the right approach to what do we have now to work with. So we're definitely working through the balance of that as well.
So Tasha, this is Danette Smith. And thank you, Ryan, for that response, because you hit the nail on the head. You really did. In some of the experiences I've had, we've used law enforcement as a partner, and they see their role more as a partner, not enforcement. And so I think there's a couple of things that have to happen. Number one, they're going to have to be a part of some of the work that Gwen is talking about, okay, to really understand where we want to take the system. So they're going to have to understand what it means to be a part of the system. Number two, I think, yes, it's training, but if law enforcement isn't at the beginning of creating some of these programs and co-creating it with us, we will only call on them when we think it's about a law enforcement issue, when it's really a mental health issue. And I'd just like to give a quick example and then let Gwen get back. In Virginia Beach, I had a co-responder team, and I think there's some of that going on here in Colorado, where I had a social worker and I had a law enforcement. They were the team that went out and kind of did the house call. And if it was a mental health issue, we triaged it there and got the person to services immediately. In the city jail, we also, and you may be doing some of this and I'm learning, so I may be repeating myself. In our jails, we also did a lot of assessments to make sure that we were assessing people when they were incarcerated in the city or county jail, so that when they left, we had a treatment plan for them into housing with medication. So that what I'm sharing this because law enforcement saw themselves differently than law enforcement. They saw themselves as a partner in helping in behavioral health. And so I think all that Gwen is talking about is spot on, and Ryan as well. We've just got to get our law enforcement to see their role differently. Yes, there's a role for law enforcement, but there's also a role in a different way of doing it when it comes to behavioral health. And sometimes behavioral health gets locked into, we're going to arrest you. So there are examples throughout the country where some of this is happening, and it may be also happening here in Colorado. I just think we have to bring law enforcement on more as a partner instead of just law enforcement.
Thank you so much, Danette and Ryan, for articulately rounding out my response. I really appreciate it. And I think that's really inspiring, Danette. Carolyn, did you have a question or comment?
Yes, I do. I've had some experience with my son being in and out of jail, and my frustrating thing is, like, he was on specific medications. So jails are limited to a very few medications. And then when I take him in his medication, he when he left, you know, he didn't have his medication, you know, because they don't give you anything when you leave. And many times I've seen people come out of jail that would come into our drop-in center and didn't know where to start and what to do. And it's so much and it's overwhelming that they're not able to do it. And so they revitalize back into the jail system. So it's like once they get out, nothing goes with them. And so it's really frustrating. And then I remember talking to the Adams County doctor several years ago, and he was saying, you know, they have limited medications, you know, they usually have the cheap ones because there's no funding. And he was overseeing 400 people in the jail at that time. And so, like, he was overwhelmed to the point where he's lucky if he can get to someone within 2 weeks, a new person in 2 weeks after they've been there. So they're already going through withdrawals of medication, withdrawals from a substance, you know, and really struggling. And then when they do get evaluated, by the time they get out and they're on medication, their medications don't go with them. So anyway, I just see this as a big trap, and I've had experiences with this trap. And this is something that I would really hope that with the BHA involvement, that some of this can get resolved where people are being seen by care coordinators to support the doctors in the jail, you know, so that people are being able to be served and have their services continue, them to be able to leave with medications so that they can stay stable enough to be able to reenact their Medicaid and can be able to get back into services.
Thank you so much for bringing that scenario here, Carolyn. I think that it's safe to say that the type of partnership that our commissioner is envisioning with law enforcement and corrections even is one of the ways that we can move towards better care for people who are struggling with mental health issues and are in jail. I really appreciate that. Our incompetent to proceed to short-term certification pathway is just one piece of that puzzle. But thank you for bringing your comments here. I don't see anyone else with a hand up at the moment, so I'm going to move on to our training programs, and then we'll have a little bit more time to open for questions, I think. So care coordination has a trainer as well. And our trainer is funded by Senate Bill 22-177. And what she is doing right now, what she's working on, is a statewide care navigation certification that's being created in conjunction with the University of Colorado and will be deployed in the OwnPath Learning Hub. What that means is we have somewhat of a workforce shortage that's been acknowledged in the state of Colorado, and care navigation certification is meant to give people access to a free training that explains what care navigation is and how to do it, so that we can get more people in to assist the clinicians and the doctors in getting people all the different types of care that they need. So we're very excited about that. Our statewide care navigation certification will launch on July 1st and will be available again through the OwnPath Learning Hub. Our trainer also offers training to providers and judicial on emergency department assistance and for both of our civil certification programs. So she is a busy gal. Her name is Callie Lickness. You can see her email down at the bottom of the screen. Kelly offers office hours the first Monday of the month at 11 and fourth Monday of the month at 3. These are for providers or anyone who's participating in ED assistance or civil certification programs to ask questions, to find out when the next training is being offered. And people can email Callie if you know of a provider who would like to take advantage of ED assistance but doesn't really know how to make that connection, etc. She's great and willing to help. So here's our formal question and answer time. So does anyone have any further questions for me? And I have not really been looking at chat. So if there were questions in chat and you feel comfortable to raise your hand and ask those questions, please do so now.
And Gwen, I wanted to point out to you, I've been answering what I can in the Q&A, but there's an additional question in the Q&A that we can also get to during public comment to allow more time for Q&A during the presentation. So whoever asked that question that's still in Q&A, we have not forgotten you. I just wanted you to know that we will bring it up in the public comment.
Renee, it looks like you have a question / comment. If you're speaking, you're muted. Thank you.
Okay, can you hear me now?
Yes.
Okay, so I just have a concern, a question regarding the co-respondent team that is in many communities. One thing that's concerning is in the small rural areas that there's still what's the word I want? There's still like a club, I guess, that everyone seems to be involved in if you're involved with any kind of law enforcement or the co-responding team, and it's like they're all good buddies. And so there's issues that are happening in rural areas because everybody knows everybody and everybody is buddies with everybody and blah, blah. My concern is that I see, and not just in my area, in other areas in the state that I work with, that there's a sense that law enforcement is the only and ultimate responsibility. They're the ones that have the authority. They're the ones that do whatever. But when there's these kids that have behavioral health issues, where does it fall that is what the focus should be, not their criminal, not they got an MIP because they were drinking at a party or whatever. Where does it lie that that's what we need to be taking care of first, is their behavioral health, and not involving the police, which causes more trauma to the situation. And the co-respondents aren't thinking of their mental health first, I guess. It's a real concern in the rural areas.
Thank you for bringing that forward for us. As the care coordination director, that's definitely a concern for me and a concern for the BHA. I think, again, I want to highlight that we do have a program within statewide programs that works on crisis and co-response and those types of things. And hopefully we can address this in the upcoming topics that they might share some of their programming in. And then I wanted to welcome anyone else from BHA to share any knowledge that you have or additional comments that you may have in response to Renee.
Renee, this is Danette. I can tell you in Nebraska, we were starting to explore, and this isn't the answer. I'm just saying that this was something we were exploring because we had the same problem in our rural and panhandle communities. And one of the things that we were starting to explore with law enforcement is how we could use schools and telehealth after hours to assess kids' behavioral health needs. One of the things that I learned in Nebraska was that most communities, rural communities, felt the schools were a safe place. Don't bring the kids to the jail, let's take them to school. What could we set up in a school environment to support kids? We have begun to look at what could a program look like? Because it can be such a panhandle in Nebraska, how could we then get the child to school with parents and do some assessment kind of from a telehealth model? We were beginning to explore that. That's not the answer, but we were starting to see, what options are out there for us to use with current community resources. Now, of course, we hadn't had conversations with superintendents yet, because that might mean more money, whatever, but just the idea of where could we create kind of a triage center for kids when things happened, and to not make it all simply law enforcement. So you assess the house call, but you also assess for behavioral health, and you get them to a safe environment where you can have that real conversation. So I just offered that as something that we were exploring.
And this is Kelly Kazi, she, hers. I wanted to just elevate, thank you for bringing that up. And I lead the Children and Youth Plan along with Matt Holtman for BHA. And it's absolutely one of the issues that have come up that we've heard from community. You're not alone in raising this. And we don't have the answer for that right now today. It is, though, part of the plan and the work that we're doing with the working group with the other state departments on how do we address this, resource it, have the screenings and assessments in the right places with the right people for our young adults and kids. And so thank you for elevating this. And I look forward to being able to come back to you all with the steps that we're taking to help address it. So thank you for raising it.
Renee, I think I'd like to take your information in the chat, because what I want to do, you mentioned a number of things, but one of the things you mentioned is that the co-response team doesn't seem to be functioning optimally. And is there, I would like to find out on your behalf if there's a way that you can, or people in those communities can make a complaint or can elevate that concern in a way that it can be addressed. And so I will take responsibility for getting back with you on that. And then I would like to move on to Carolyn at this point.
That would be great. I will try to put my information in the chat. It doesn't always work, but I will try. Otherwise, Megan, if you could just give it to her, that'd be fine.
Yes, I was just going to note really quickly, Gwen, I've been taking some notes for you to follow up on some things. So those are being an email for you, and I will include Renee's information there for you as well.
Thank you so much. Megan, would you do me a favor and let me know if we're at time and needing to move forward? But I think I'll take Carolyn's question now as long as we have time.
We have 4 minutes, and actually 3 minutes. I need 1 minute to close out the meeting, but you have 3 more minutes of questions.
Okay, Carolyn, please go ahead.
Thank you. I just want to share that my experience with working with schools in the past, Commissioner Smith, is like they're notorious in the Denver metro area for putting the blame on the parents when the parents are seeking support from the schools with help with their adolescents. And the schools are notorious for putting restraining orders against the parents, which leaves the school in control of the children, and the parents have no support with their treatment or anything else. So and I learned all this from working with parents. I know the federations for families for children with mental health have been really helpful at educating parents on how to advocate, so that in a way to where they will not get restraining orders against them. Because I think the parents just get frustrated with the school gets frustrated with the parents, and so it becomes a big battle over the poor child, and I agree with you. I think it would be really nice if the schools were supportive and not putting the blame on the families for the children's behaviors or conditions, and supporting the families along with the children instead of creating separation. Thank you.
Carolyn, it's Danette. I received your feedback. Thank you.
Thank you, Carolyn, and thanks everybody. I think Megan, I'll turn it back over to you at this point.
Thank you, Gwen. I will go ahead and bring to your attention a couple of questions that are in the Q&A. We still have another minute before we close out the meeting. Do the clients have the ability to reject a placement based on the safety and quality of care at that facility?
So in terms of certified clients, because this is part of an involuntary process, my understanding of how this works is that the evaluators, so the person who's writing the petition for short-term certification, or if we want to float over to the emergency mental health hold process, which works in a similar fashion, that we're gathering as much information as we can from that person, and based on our knowledge of the facilities available, we are placing the person. Now, during the course of our evaluation or the discussion with the person who's going to be certified, if they've had a bad experience at a facility, or if they prefer not to go to a certain facility, we try our best to take that into account. But we also don't want to allow them to languish where they are. And so, yes, the short answer is yes, we do try to take that into account if there's a specific request not to go somewhere. And we also have to be cognizant of how much capacity is available in our state as well. So we try our best, but sometimes the facility with an opening is where we have to send someone because it's better than continuing the incarceration, if that makes sense.
Thank you, Gwen. There are a couple of comments in the Q&A. One is this type of collaborative work is being done throughout the state collaborative management program counties. Lots to learn from the different work being done. Schools are a huge part of this process. And then an additional comment is truth, schools are not helping hands when it comes to behavioral health needs. And one more comment, thanks for all you're doing, and for this person is thanking for being in attendance and welcoming Commissioner Smith, and thank you for serving the people of Colorado. And I believe that's directed specifically at Commissioner Smith.
Megan, was there a question for me in there that I may have missed? I'm sorry.
It was just some comments, to you. And those comments to you, Gwen, again, they're in notes that I will send to you after the presentation. So you'll have all of those comments as well.
Wonderful. Megan, time for a public comment.
Yes, thank you, Raquel. And as we move into public comment, you may raise your hand to make public comment, or if it is your preference, you may put your public comment into the Q&A, and we will answer it live for you. And keep in mind, if you are asking a question or making public comment live, we do limit each person to 2 minutes. And right before we move to public comment, I did want to thank everyone for being here with us today. Thank you for a really collaborative meeting. This feels like co-creation to me. I think this is our best meeting. I know, hands down, this is our best meeting we've ever had, and really appreciate all of your meaningful questions and bringing so many different perspectives to the table. This is what we were meant to do. So thank you, BHAAC.
Absolutely. So public comment, first hand that I saw raised was Michelle Voss. Hopefully I said your name right. Michelle, you have 2 minutes.
I didn't raise my hand. Sorry.
Oh, okay. That's okay. I'll put it down. Thanks, Michelle. Next one I see is Mehen, and I may be saying that wrong. Lovelace?
Megan
Lovelace. I'm trying to sound fancy. My mom's from France. I always want to put a twist on names. I apologize.
No worries. Thank you. It's pronounced Megan. I blame
Megan.
my parents who are from Ireland and I believe spelled my name wrong. My comment is for Gwen. I'd also like to welcome Commissioner Smith. Welcome. We're so excited to have you. Gwen, in regards to the comment around sort of like filing a grievance or maybe bringing a not so great crisis response experience to leadership, I believe there's a lot of fear of retaliation within communities towards actually speaking out and speaking up about some of the experiences that rural communities specifically have had in regards to crisis response. So I would encourage yourself and your team, as well as the larger Behavioral Health Administration, to think creatively around ways that we can look at how to address situations that don't have the outcomes that we are hoping, right? Without identifying those individuals, because oftentimes those are the only service providers in rural communities. And if we speak out against some of our experiences, we maybe won't have positive experiences moving forward. So we may never speak out about those experiences. Therefore, the BHA may never hear what's going on. What ways can we do this anonymously to feel safe in our own communities when experiencing crisis?
Thank
I
you.
don't know how to mute myself, so I think someone needs to mute me. I also want to be a part of Ryan's rap group, please.
Thank you so much, Megan. So thank you for elevating that, because I think that's an issue when we're talking about rural co-response teams. I've also seen that as an issue when my care coordination team is responding to people who are in the hospital on behalf of a relative who may be in the hospital but is worried about retaliation within that hospital system. So I will take that under advisement, and as we move forward with putting together grievance systems or allowing people to have that feedback loop, making sure that we're protecting them as well.
Thank you. Anyone else? Do we have anything in the Q&A? Here we go. I've got one. It says, hi, my question is, how does the BHA plan on collaborating with Denver Indian Health and other resources when implementing policies and plans?
That is a great question, and I can take that. I am very excited to share that we have posted our vacant position of Tribal Affairs Specialist. And so we will continue to move that work forward. And in the meantime, while we have not had a Tribal Affairs Specialist at the BHA, while we've been in that transition, we've been leaning very strongly on Philip Gover, who is the Tribal Affairs Specialist at CDHS, who will continue to support the BHA and our Tribal Affairs Specialist as well.
And the person says, perfect, thank you.
You are welcome.
Any other questions or comments? I'm scrolling through the Hollywood Squares. Ooh, I stretched it out and I can see more faces. And it looks like we have none, Megan.
All right. Wonderful. Raquel, thank you for chairing this meeting. You've done a fabulous job. Thank you to everyone for being here today. I appreciate all of the BHA support staff and all of the BHA staff that are also in the background that you can't see on your screen today, because they are making sure that all of the Zoom logistics and all the things necessary are happening. And so very much
I want to say thank you, Megan, and I want to say BHAAC, way to stick in it, y'all. We made it. We made it to a beautiful meeting. We stuck together. We have a new commissioner. Megan, thank you for keeping us moving through our transition. Just thank you. Ryan, everybody here, thank you. We made it. We did it. Thanks for not giving up. Our perseverance is obvious.
Raquel. Yeah, this has been wonderful, and I'm really excited for our May meeting and the continued work that we will continue to do in co-creating. And Commissioner Smith, thank you so much for being here
Welcome.
and jumping in and interacting with us in our meeting today. Much appreciated.
Have a fabulous day, everyone.
All right. Thank you all. Raquel, you can
See
close
you in
out
a month and a half.
Gotcha.